Hi, everyone. Welcome to the Advanced Treatments for IC webinar. Today's session features Doctors Jennifer Anger, Karen Eilber, and Victoria Scott. This webinar is presented and sponsored by ICA's corporate partner, Femetry. Thank you for your support. Please note that this session will be recorded. If you are on camera, your video will be included in the recording. We will have a Q&A session following the presentation. To ask a general question related to this topic throughout the session, please use the chat feature. Once the Q&A session has started, you may also use the raise hand feature in Zoom. You will be asked to unmute yourself. If you aren't speaking, please be sure to stay muted. The doctors will answer as many questions as they can during the webinar. And finally, please complete the post-webinar survey. A link to the survey has been posted in the chat. Okay, it's time to get started. Without further ado, please welcome Doctors Anger, Eilber, and Scott.
Thank you so much for the introduction, and thank you everyone for joining us wherever you are. It's either noon on our coast or 3 p.m. Eastern time. Today we're going to talk about advanced treatments for interstitial cystitis, which hopefully will be able to give you some insight as to treatments that are offered and what's reasonable and maybe what's not necessarily considered on label per se. And yeah, like Jen Lee mentioned, hopefully we'll be able to answer all of your questions. So a fundamental question gets asked all the time before talking about any treatments is, what is the cause of interstitial cystitis or painful bladder syndrome? And the bottom line is we don't really know, which probably all of you on this call are already aware of. But one of the predominant theories is that there is a defect in this glycosaminoglycan, or what we refer to as the gag layer of the bladder. And this results in increased sensitivity and pain. And another theory is that there is just a defect in the pain receptors. And one of the analogies that I often use with my patients is one of the theories why people have autism is they can't filter out all of the sound. I think the people who have pain receptor issues, your pain receptors can't filter out what you're not supposed to be feeling, so you're hypersensitive to a lot of things. So this glycosaminoglycan layer, if you take a view of the image on the left, all those little blue lines represent what an intact gag layer would look like. And this helps the barrier. Like also farther left of the blue lines are things that are basically excretory elements in the urine, which also makes the urine acidic, different types of bacteria and other organisms. And on the right, where you see these defects, if they don't have this protective gag layer, all of these things can then penetrate the bladder wall and cause subsequent irritation and inflammation, which results in those typical symptoms of IC, which are urinary frequency, urgency, discomfort, and unfortunately for some people, severe pain.
So what we don't know is, and we think there might be variation between different patients, or what we call phenotypes or subgroups of IC. So we don't know whether there's a defective gag layer in some patients or in all patients. In many patients, the majority actually, their bladders, when we look with a camera, look normal. And so some patients, we definitely see what we call Hunner's lesions or Hunner's ulcers, where we can physically see a defect in the gag layer or in the epithelial lining. But again, many patients, it's totally normal. So what we see here is this phenomenon of what we call pelvic pain only versus widespread pain. And we see that up to 38% of patients with IC have other pain, other areas in their body that have pain, chronic pain, back pain, migraines, TMJ. And often when I see patients, I will explain that I think of IC in many patients as kind of a migraine of the bladder. So we don't know why it happens. We don't always know why it starts, but our goal is to help control the pain. Next slide, please. And it may be that there is what we call neurologic upregulation of pain, so that once you have pain, that it actually basically you become more sensitive to pain. And there's certain phenomenon associated with chronic pain, what we call central sensitivity, that this initial bladder event, or let's say someone has an episode where the gag layer is defective, they have pain in their bladder. But once that becomes a phenomenon, they are then more sensitive or more susceptible to experiencing this pain again. Next slide. And so what we don't know is whether or not IC can develop in men too at the same rate as women. Interestingly, there's very different data on the proportion of patients who are men and who are women with IC. And what we used to think is that it was much more common in women. And now we're like as high as 10-1. And what we're actually seeing now is that the ratio is much lower. It might be more like 1.6 or 2 women for every 1 man. And what we see is that women tend to be more likely to be diagnosed with men than men with IC, and men who may have IC are likely to get misdiagnosed or treated with something else. So we really are focusing on trying to identify men who suffer with IC as well. Next slide.
All right, so today we really want to focus on our more advanced treatment options for IC, but our lifestyle changes and behavioral modifications are really our building blocks of any therapy. And even if we advance to medications or procedures for our IC patients, we really always kind of come back to making sure that, if someone does have a flare, that we're really focused on making sure that we've optimized our lifestyle and behavioral modifications. So to briefly touch on these, stress reduction, I'm sure you've all discussed this with your doctors before. We know that stress makes us more hypersensitive to pain. So certainly anything we can do for stress reduction tends to help IC symptoms. Improved sleep, we know that IC can wreak havoc on your sleep. And so certainly anything we can do with sleep hygiene to improve sleep will help reduce stress and make life better. Exercise as tolerated is certainly super important for patients with IC. Diet, we know that most patients with IC are very sensitive to bladder irritants. And so ensuring that we're maintaining a diet that's tolerated by our own bladder. We always tell patients, there are very restrictive elimination diets you can try, but it's always good to slowly maybe introduce some things that you love back into your diet to see if you can tolerate them once you've removed all the more aggravating factors. Improving sexual function, we always like to talk to our patients about this and making sure that we're doing everything we can to optimize their sex life, because we know that IC can certainly make sex more painful, and this can lead to a lot of fear and apprehension about sexual activity. And then finally, supplements, non-prescription medications can be very helpful for a lot of patients. So for prescription medications, the American Urologic Association guidelines really focus on 4 different medications. The antidepressant category, primarily amitriptyline, we have the most data on, and this is really focusing on, as Dr. Enger mentioned, the centralization of pain and more of the nerve component of pain. So the tricyclic antidepressants are at higher doses used as an antidepressant, but in low doses, research has shown that they can help with a lot of pelvic and bladder pain. They can cause sedation and drowsiness, so we certainly recommend taking them at nighttime, sometimes weight gain as well. But for some patients, they can actually help with the sleep issues as well. Elmeron, so pentosan polysulfate, this is a hot one right now. This is our only FDA-approved medication for IC, but as many of you are probably aware, the FDA did recently, well, probably about 2020, I believe, issued some warnings about this medication. So we found that it can actually lead to macular degeneration and vision issues. So the guidelines now really emphasize that if you are on this medication, that you should really be seeing an ophthalmologist for retinal exam at least every 6 months or so. If it's something that you really want to start, then certainly important to see an ophthalmologist, particularly if you have any ophthalmologic issues. And then as doctors starting this medication, we should always do a good ophthalmologic history with patients before we start it. I would say, just in talking to Dr. Eilber and Enger about this, in our practice, we have been trying to avoid starting patients on it, but we do definitely see some patients who come in and they say, look, I've been on this forever. It's the only thing that works for me, in which case we just make sure we have a good informed discussion and they're really plugged in with their ophthalmologist. And then our last two medications, cimetidine and hydroxyzine, are like antihistamines, so kind of like Benadryl, and they work on blocking histamine release. Histamine causes a lot of inflammation and irritation, and so these medications are used kind of under the theory of reducing the inflammation in the bladder that could be contributing to a lot of the IC symptoms. Next slide. So to dive into our procedure options, again, all these are supported in the AUA guidelines for IC, so they've all been studied. We have intravesical bladder installations. These are smaller procedures performed in clinic. We can do cystoscopy or a camera test where we take you to the operating room, we take a small camera, look in the bladder, and we can distend the bladder. We can burn Hunner's lesions if we see any, or inject them with a steroid. Neuromodulation, onabotulinum toxin A or Botox injections, and then finally a cystectomy. So bladder installations. This is our least invasive treatment, or invasive treatment option, I should say, for patients with IC. We do it in clinic. We take a small little catheter or little tube and place it directly in the urethra and bladder. And then we instill a cocktail of medications into the bladder. So the benefit is we're instilling the drugs directly into the bladder, so much less risk of systemic side effects. The downside is it is a procedure, so of course it can induce some pain. And we often tell our patients it's not uncommon that with bladder installations, initially you may have a flare, but typically the pain does get a lot better. There's a lot of research on different cocktail options, and we don't really know the best regimen or even the frequency, but typically we'll recommend weekly installations as an induction course for about 6 weeks, and then maintenance installations as needed. And this is different for every patient. So some patients find that they do the 6 installations and then they're fine for a few months, maybe even a year or so, and they just kind of come back for rescue installations if they have a flare, and then maybe would do like 3 weekly installations. Some patients find that the bladder installations are a good part of their maintenance regimen and preventing flares. So they find if they come every 3 months for an installation, that tends to prevent flares. Or if they know they're going to be in a stressful situation. So we can really play around with the regimen and tailor it to each patient, depending on how they find that they help them best. Common ingredients do include lidocaine, so this is just kind of numbing and soothing for the bladder. Heparin is supposed to help rebuild the gag layer. Dimethyl sulfoxide or DMSO, this is known to reduce irritation, possibly have some muscle relaxant effects. The sodium bicarbonate alkalinizes the urine and most likely makes the bladder lining absorb the other medications more readily. And then Elmeron, sometimes we'll put this in a bladder installation as well. Typically, we'll do the installation in our clinic, either performed by a doctor or one of the nurses. Again, the installation itself is about 15 seconds or so, but the appointment might be 10 to 15 minutes. And then you'll usually try to hold the solution in your bladder for about 2 hours. With the exception of DMSO, that one we tend to have a much shorter dwell time because it's absorbed more rapidly, so that might be more like 15 to 20 minutes. Next, we have cystoscopy with steroid injections or fulguration as well. So this is a procedure. It can be performed under local anesthesia, but more commonly we're going to do it in the operating room because patients with IC have such sensitive bladders that we typically really don't want to risk causing you severe pain in the office. So again, we'll use our cystoscope or the teeny little camera. We'll look in the bladder, we'll inspect the lining of the bladder. Typically, if we've decided on cystoscopy with steroid injections or fulgurations, we may have done a cystoscopy, and a very gentle cystoscopy in clinic. And we've seen some Hunner's lesions or ulcerations in the bladder, as Dr. Enger mentioned. It's rare, but they can occur in about 5 to 10% of patients. And we do know that if we see these lesions, we should absolutely treat them because this will improve your pain. And so we will often either inject them with a steroid and or cauterize them. And this typically helps the bladder lining heal and leads to good resolution of symptoms. They do tend to recur, and so certainly if we've done this procedure, you've had good success, and then maybe a year or so later symptoms come back, we know it's a good time to check the bladder again because the Hunner's lesions may have recurred, and then we may need to perform an injection and or fulguration again. And then finally, with the cystoscopy, we can also perform a hydrodistension. So this is like a stretching of the bladder. We do this under anesthesia as well. The theory here is we're stretching the bladder, so we're disrupting the nerve pain signals that are being sent from the bladder. It's not disruptive enough so that we destroy all nerve sensations. So you're still going to feel when your bladder's full, you know, all the normal bladder sensations. But the main one that we're trying to fix is that pain. And it's pretty successful for patients as well. Again, this is one of those where we warn patients, there's a good chance you're going to have a flare of symptoms before it gets better, but oftentimes pain will get a lot better. So what we'll do is we'll gently fill the bladder to gravity. And this is really important because we don't want to over distend your bladder. You're asleep, so you can't give us the feedback that, you know, you're feeling pain or the bladder's full, or we're stretching beyond the functional capacity. So we'll fill to gravity at a low pressure. This is about 60 to 80 centimeters of water. And then we'll hold the solution in the bladder for about 5 to 10 minutes. And this stretching often does work very well for patients, although again, it's usually temporary and something that we do tend to have to repeat.
All right, thank you, Dr. Scott. We're going to move on to what is considered neuromodulation, and 2 treatments fall into this category. Neuromodulation, if you were to ask us how exactly it works, the real answer is no one knows exactly, but we do know consistently the result that it tends to give. So a good comparison is, scary as it sounds, we don't know exactly how anesthesia works, but we know the consistent results of it. So one general way of thinking about neuromodulation is we're kind of overtaking the abnormal impulse to an organ. Although interstitial cystitis as a diagnosis is not an indication for neuromodulation, because people who have interstitial cystitis have urinary frequency and urgency, this can be covered by insurance for those who suffer from those symptoms related to their interstitial cystitis. So we use this device oftentimes also off-label for pelvic pain. And the good thing about both of the modalities that fall under neuromodulation that I'm going to discuss is they're pretty much reversible. So the first one we're going to talk about is posterior tibial nerve stimulation. And if you look at the photo on the woman sitting in the chair on the right, you're like, why is there a needle in her ankle? Well, this is basically, and the manufacturer of this doesn't like when we say this, but it's basically acupuncture is what it is. And the nerves of the bladder start in the pelvis, of course, and they end in the inner ankle. So when you apply the treatment to the posterior nerve, it eventually in a retrograde or backwards fashion will go to the main nerves of the bladder. The way we know that this is placed in the correct position is when the needle is in, when we turn on the stimulation, which literally is electricity, someone's foot should feel like it's falling asleep or tingly. Sometimes you'll even see someone's toe move. And the landmarks that are for this are the tibia or the bone in the leg. So we usually can get the needle in the correct position pretty frequently. In general, people have to have at least 3 or 4 treatments in a row to see any difference. So the initial treatment is once a week for 12 weeks. When this device came out in the clinical trials, the great majority of people had some response by 6 weeks. So for me personally, if I have someone who has had 6 treatments and has noticed nothing at all, I don't find that it's worth going to all 12 treatments, because in those same clinical trials, they didn't really see much benefit for anybody who had no response after 6 weeks. So at the worst case, you've maybe wasted, if you will, six different treatments, but at least you'll know that if it doesn't work, it's no harm, no foul. You can move on to the next thing. And it's also a very subtle thing. So usually after about 3 or 4 treatments, someone might say, yeah, you know, I realized I was getting up 4 times at night. Now it's only 3. And ideally by the end of the 12 weeks, someone is getting up a lot less. Also, after the initial 12 weeks, there is a maintenance period, which the recommended maintenance is once a month. I have found that most people will regress if you go from weekly visits to once a month. So I usually have my patients do a few treatments every 2 weeks, then a few every 3 weeks, and then get them to their maintenance of once a month. And the next neuromodulation treatment is called sacral neuromodulation. This has actually been out since the late 90s. It is very similar technology to a heart pacemaker. So we sometimes refer to this as a bladder pacemaker. So just like the tibial nerve stimulation, although there is not an FDA-approved indication specifically for interstitial cystitis, it is approved for urinary frequency, urgency. It also has approval for non-obstructive urinary retention. So in English, as long as you don't have a physical blockage, maybe it's a functional blockage, especially people who have chronic pelvic pain who cannot relax their muscles to urinate easily. This is a good or potential device for that. Also in the last, I don't know, Dr. Zanger, Scott, if you can remember, somewhere in the last like maybe 5 to 8 years, it also got indication for fecal urgency and fecal incontinence. So for people who have multiple issues, this device can really be a game changer. There's a lead or this wire, which you can see in the photo, that goes from the battery, which is that kind of silver thing on the right side there, that goes alongside the nerve to the bladder. So it's important for people to understand this does not go into the spine. So there is not a possibility of having spinal injury with this device. It's usually done on one side. There are some people who will implant on both sides. I personally don't do that. Nobody wants to have an implant in unless they know it's going to work for obvious reasons. And in general, for about 70% of people who have those symptoms, it will work, but for 30%, it doesn't. Because of that, there is a test phase. So the test can be done one of 2 ways. The easier way, both for doctor and patient, is in the office. We numb the area where those nerves are, which is your low back, which is sacral nerve number 3. And we put a temporary pacemaker, if you will, using landmarks of the bone. If you have x-ray in the office, we also use x-ray. Someone will wear a temporary device for a week. Unlike the tibial nerve stimulation that takes several weeks to see a result, you really should see a result of this within a week. And if that does work, then a permanent implant is scheduled. Another way to do a test is called a staged procedure, where you go to the operating room 2 times, and this is often what we need to do for patients who have things like interstitial cystitis, because quite frankly, I think it's kind of mean to take someone who has chronic pain and do an office procedure. So I think it's a little more humane for a lot of people to offer this with sedation. So while they're asleep, we'll put a temporary device in, which if it works, it's actually the first stage of the permanent implant. So I know it can be confusing. In the office test, it is a totally temporary device. At the end of the week, we remove it. If you do a staged procedure, what is intended to be the permanent wire is implanted, and it's placed in such a way that it should not get infected. So in the second stage, which is generally 1 week later, we just attach a battery. So there are 2 short procedures. There are 2 anesthetics, but for people who have chronic pain, it is kind of a better way to go to have anesthesia. Next slide. And I kind of went over this. So the 2 ways to perform the procedure is you place the wire, or what's called the lead, inside the body with a temporary battery. And someone needs to have a minimum of 50% improvement. And it's not that we're aiming for someone to only be 50% better, but in the test, if you have 50%, when the final implant is in, there can be adjustments made to improve it. But within that first week, we like to see at least 50% improvement. And this kind of just repeats the same thing. The external battery, sorry about that. The external thing that you see there, everything is taped to someone's low back. So it's just kind of an annoyance for that 1 week, because you do have something taped to your back. And really the only limitations are, no exercise, and you don't want to get sweaty to have the dressing off. But again, for a lot of people, doing a test in the office for something that can really help them, not just their frequency and urgency, but I've had some people, when we use it off label for pain, have significant improvement in their pain as well.
And I've done, I will do bilateral interstim or sacral neuromodulation for patients with pain. And like Dr. Eilber said, even though we get it covered by insurance because of the frequency urgency indication, I've had patients that really just had pain without frequency urgency who did really well with it. And so I think that for patients with IC that's refractory to medication, I think in my best results have been with neuromodulation, and really it makes seems to make a big difference. It's not as effective for interstitial cystitis as it is for overactive bladder, which is its most common indication, but it's definitely worth a try. And even though it seems, oh, this is invasive, it's really, not that invasive. If it doesn't work, you have a little scar over the buttock area. So, well, what else do we have? Dr. Eilber and I are both participants in a trial. It's actually a randomized trial looking at Botox for interstitial cystitis by AbbVie. And many of you know, I know, at least I'm no stranger to Botox, and it paralyzes the muscles. That's why it works in the forehead. When given in the bladder, it partially paralyzes the bladder muscles, so it will calm the bladder down. And so it tends to work the best for people with frequency urgency and leakage, but the majority of patients with IC also have these overactive bladder symptoms. And there is some preliminary studies that show it also helps with pain. This is done, it can be done in the office. Again, like Dr. Eilber said, I don't like putting patients with pain through pain, so we can also do it in the operating room with some sedation or anesthesia. We usually do a small amount of Botox, which is like 100 units. The biggest risk of Botox is that within 7 to 14 days, it can work too well where the patient has difficulty emptying their bladder. In particular, where they can't pee and need to temporarily use a catheter. When we say temporarily, it's usually not more than a few weeks, let's say 4 to 6 weeks max, and then the Botox will tend to wear off. But the nice thing about participating as a trial that's randomized is we should soon have, data that shows us, is this actually effective in IC? But it looks like preliminarily it is, at least in some patients. Next slide. So now I want to talk about, this is sort of the when all else fails. Now, and before we get to cystectomy, which is removal of the bladder, another option to test if a patient is a candidate for bladder removal is to place either an indwelling urinary catheter through the urethra or what's called a suprapubic catheter. So we actually we can do this under anesthesia, or interventional radiology can place a catheter that goes directly into the lower abdomen, right above the pubic bone. The urine will then drain to a bag. And so for patients who have severe pain with bladder filling, putting the urine directly to what's called a leg bag, where the urine will go to the leg, will relieve their symptoms. If they have, let's say, a bladder that's more end stage, meaning the patient's had IC and their bladder doesn't stretch normally. So before going to cystectomy, I will usually do a test where we try a catheter to see if the catheter relieves the problem, then very likely cystectomy will relieve the problem. Cystectomy is removal of the bladder. This is not something we take lightly. This is a big surgery. And what it entails is removing the bladder. There are cases where you just divert the urine into a separate, basically you can see on the top, right? That's a stoma. So we take a small piece of intestine, connect the ureter tubes to that piece of intestine, and the urine will go continuously into a bag. So that can be done actually without removing the bladder. However, patients who have had IC, you know, we talked about that phenomenon of central sensitization. Even if the urine is diverted, they may still have ongoing bladder pain. So we tend to remove the bladder when we do these diversion procedures. On the lower right, you can see an option which is called a catheterizable stoma, where the bladder is removed, but then a new bladder is created out of intestine. And then the patient can catheterize that little, if you see the little stoma on the lower right-hand corner, and that means that they can allow their bladder to fill and have no bag, but then when they need to empty their bladder, they can put the catheter in and empty the bladder. So that's a nice option. However, there are reports of patients who have had interstitial cystitis, and we do see reports of them developing pain in the new bladder. So my preference for patients who have who are undergoing cystectomy is to create this ileal conduit on the upper picture where the urine goes directly into a bag that's right on the abdomen. And then even though it sounds kind of dreadful, patients who have it have a huge amount of relief, and the pain is usually not an issue any longer. Next slide. And I think that wraps up our talks, and we would love to, we see a lot of really great questions on the chat, so we can go ahead and move forward to the Q&A. I don't know if Dr. Scott or Eilber had any additional comments they wanted to chime in before we move on.
I think the only thing I want to add is, you know, like all the patients that we see, you know, you can see the frustration, you know, in some of the chat comments. IC is one of those conditions where I would love to say we have a magic bullet, but it's typically multimodal. It is working with your doctor, physical therapist, nutritionist, whoever, and it's an ongoing thing. So I just want to remind everybody that, you know, it always makes me sad when patients say, you know, they didn't feel like they could have an open conversation or ask questions, or they're embarrassed to suggest things. So even if something isn't appropriate, I want my patients to throw things out there, you know, whether they think they want to try whatever herb or supplement or something, as long as it's not going to harm them, I think it's okay. My job is, you know, to keep them out of trouble. But some of the things that we recommend are things that our patients have told us over the year that we would not have known otherwise. So just want everyone to know that it is multimodal. It is a team approach. And hopefully you'll be able to find someone, you know, that's in your corner that's willing to work with you to alleviate your symptoms. So with that, unless Dr. Scott, you have a comment?
Yeah, sorry, one more thing to add. Along the lines of the importance of the team approach, this isn't exactly in the AUA guidelines. We do really try to stick to the guidelines, but Drs. Anger, Eilber, and I have worked pretty extensively with our pain management colleagues as well. And not pain management in the sense of like narcotics. We absolutely really try to stay as far away as we can from narcotics, but more in the procedures they can do with injections. So I think that's another specialist to absolutely consider seeing if you haven't already discussed it with your urogynecologist or urologist and you feel like your pain's not being adequately treated. So they can perform injections in the pudendal nerve, particularly if you have some concomitant pelvic floor muscle dysfunction. And they can do larger nerve blocks as well. We can do pelvic floor blocks, and then physical therapists also who can help with nerve and more muscle release. So those are just other things to consider.
And maybe just to start, I'd love to just take the question about Elmeron, only because my Dr. Lowell Parsons was the man who invented it, and I work with him at UCSD. So I've had a lot of conversations with him about Elmeron. And I think, and we've seen, you know, FDA warnings followed by lawsuits. And I think what's important about Elmeron is you don't see, you know, what largely happened was patients were aware of the warning and then they went and had visits to the eye doctor. But really any pigmentary maculopathy, which is very different than macular degeneration, largely happens, well, exclusively happens after patients have been on Elmeron for the equivalent of 100 milligrams 3 times a day for 15 years. So I think what the guideline really say is, you know, if it's working for you, just get an annual checkup with your eye doctor. And Dr. Buffington who's really great. I know him from a long time ago. He's done studies using the feline interstitial cystitis, which are fascinating. But the studies do vary in the literature surrounding Elmeron, but there are, you know, as we know, not everything doesn't work for every patient. So for patients who really do well with it, I don't usually stop it. I just make sure that we make sure it's dosed safely and that they get those evaluations. But it's hard. We don't, you know, the options, we don't have a magic pill as much as we wish we did.
Okay.
So let's see.
So I noticed that, thank you so much, doctors, for the presentation. I noticed you were answering some of the chat, some of the questions. So would you like me to just go back and kind of go through them? Okay, let's see. We have somebody that says, my docs don't want me to take Elavil because of its link to dementia. What do you think?
I really don't know that connection. I mean, the anticholinergics, I mean, Elavil is often used as an antidepressant, and the doses that are typically used for chronic pain, at least the ones that I find successful, are not even high enough to treat depression. I mean, having said that, there's risk benefit to everything. You know, nowadays, especially with our electronic medical record, if you try to order something like, you know, oxybutynin or anything for overactive bladder, there's always a concern for risk of dementia. Even on that token, because a lot of older people are also using these drugs, the question is, was that a natural part of aging versus how much really was causing dementia? But, you know, and I'm speaking for myself, it was the choice of maybe being a little off versus finally getting out of pain, I might choose the latter. But everyone has to make, you know, an educated choice. But I mean, Elavil, I don't know, Dr. Anger, Dr. Scott, you can pipe in, but there really hasn't been a lot of concerns, at least that I've heard, even from pain management people, about that.
Right. And like you said, it's the anticholinergic side effects that are concerning. What's more concerning for me, and I have, you know, memory issues in my family, so I'm very aware of memory preservation. And sleep deprivation is actually worse on your memory than something like a side effect from Elavil. And so I think, you know, quality of life, if you're able to take a med that relieves your pain and gives you sleep, it's probably going to not, it may in fact improve your memory once you're able to get that sleep. But I think, and the other thing is, you know, when we looked at dosing, you want to, you know, take the lower dose that will, you know, the lowest dose that will still relieve your symptoms. And it's probably okay, especially if you've had relief from it, or you're thinking about relief. Because I have seen when the patients take Elavil, I remember this classic when it was a young woman, she was like 19, miserable in pain. And I tried her on Elavil. And then a month later, it was like, she was like a new person. So it's always worth it. If that patient ends up being you, it would definitely be worth it.
I'm going to pop back. We had somebody ask, how does one go about finding an IC urologist specialist? And I believe there was some answering that started. So I'll just go back to that one real quick.
Dr. Scott, you want to take that one?
So in general, urogynecologist or urologist should have good training in management of IC, but unfortunately that's not always the case. So I think certainly, you know, if you're asking your primary doctor for a referral and they don't necessarily know anyone, then there are a lot of good resources online in terms of, you know, Facebook communities, social media communities that can be of good help. I think the SUFU, I'm not sure if they have a public listing of its members, does it?
I don't think so.
There are
But we can
certain
also
medical,
help. Yeah.
yeah, we're happy to help because we know probably at least a few people in every state. But there are certainly medical societies that we belong to, where we know everyone there is extremely informed. So you're right, it's absolutely very tricky. But I think just keep asking people, and certainly send us emails or whatever. We're happy to help as well.
Whether it's IC or something else, I think it's word of
Right.
mouth. And I think Dr. Scott makes a good point where it looks like you already, involved in IC and looking for someone. So if you don't have, friends or acquaintances who have IC and have a great doctor, yes, we're happy to, give references. And the nice thing about now that telemedicine is available, as long as someone is in your state, even if they're hours away from you, you can always at least do, some type of telehealth consult.
U of Miami definitely has at least 3 doctors I can think of who are probably going to be great.
Great. Next question. Can the drug Librax be helpful?
Yeah, I think any medication that is a muscle relaxant, potentially, especially if people have pain from like a pelvic floor dysfunction, from not being able to relax, from being contracted all that time of having pain. If nothing else has helped, I think it's always good, no pun intended, think outside the box. Librax is I think, a combination of a muscle relaxant and an antacid. So potentially, yes, I have not had a lot of experience with it, but I know that some people that I've seen, because they also have like irritable bowel type symptoms, will actually benefit from that for both the bladder and the bowel.
Great. We have someone that said they've been living with IC for 40 years, and they talked about treatments, including a Medtronic InterStim implant, and they said that it worked for a while, but due to some issues with the urologist, something else happened. But she just said, thank you, for your presentation, and just wanted to share that. It says, next question, can patients with FMS and disc disease benefit from these nerve treatments?
Jan, you want to take that?
Oh, sure. So in terms of the disc, do you mean, are we thinking FMS, are we thinking of fibromuscular disorders? I'm not totally sure.
I believe that's it, because I think fibromyalgia and disc.
Okay,
I think that's what they started another question.
Yes. Okay, perfect. So in terms of disc disease, like Karen had mentioned, the InterStim or the Axonics brand, they're actually beyond this, the discs. They're in the sacrum, so it's more of a peripheral nerve stimulator. The common question we receive is, if I have disc disease, will this work or not? And I usually say, well, it's worth a try because it's a peripheral nerve stimulator, but it won't necessarily help with stimulating nerves that are above that level. And then in terms of fibromyalgia, really, we think about 2 kinds of categories of treatment. One is that bladder-centered treatment versus the body, treating the whole body, or that patients who might have other disorders, fibromyalgia. So usually when you have something else like fibromyalgia, or other, let's say, migraine, we tend to treat the IC more systemically, really focusing on something like, let's say, Eilber, that's going to address pain in other parts of the body as well. However, if there is specific bladder-centered pain, ideally with frequency urgency, it never hurts to try sacral neuromodulation for the bladder-specific symptoms.
And just to add to that, because people can be very complicated, even if you have a pain stimulator, you can have one placed on the other side. Having a heart pacemaker is not a contraindication. We hear stories all the time that people are told they're not candidates for it for reasons that are actually not true. In the past, these devices, you were not able to have MRI, but you also now these days can have an MRI. And I think just back to the comment about the person who did have an InterStim, I guess the question is if you still have one, because it sounds like there was another urologist error, long story. Just because you have them before that worked, if they took it out, you can always have another one. But again, recommending you see someone who is experienced in implanting these.
Another comment on nerve issues. I think we're learning the benefit, even if patients have neurologic conditions like multiple sclerosis, Parkinson's. Now that they're MRI compatible, we're learning, hey, these are really helpful for patients with all kinds of nerve issues as well. So pretty rare that a patient would have a complete or absolute contraindication.
Great, thank you. The next question is, does this also help with pelvic pain when sitting? And I'm assuming they're referring to the nerve treatments.
I think it depends on what the cause is, if why you have pain with just sitting. You know, it can, again, it is an off-label use for pain. That's a hard one I'm sorry not to be able to answer more specific. It's a hard one to know. I mean, that's assuming that there's nothing wrong, like with the bone or with the actual, like anything anatomic in that area.
Okay, thanks. The next one
But
is,
and that's where we talk about pain management, because that sounds like that could be related to pudendal neuralgia. And we don't have enough data on, there are, you know, it's this third sacral nerve root that's kind of targeted with sacral neuromodulation. So in many cases, it could be worth trying, but when there's other pain beyond the standard indications, like if it is pudendal neuralgia, then that's when we might work on different kinds of nerve blocks with pain management as well.
okay, thank you. The next one is 2. It says, what about AZO and what about TENS treatments?
Can I take this one, ladies? So ASIO is, it's just, well, they have a few different versions of ASIO, but typically it's phenazopyridine, which is just pyridium. It's the stuff that probably everybody on this webinar has taken that turns the urine orange. If it helps, great. The only things to be cautioned about phenazopyridine are, one of the reasons why on the box it says not to use for prolonged periods is there is a phenomenon called tachyphylaxis, which if you use it too frequently, your body gets used to it. But then if you don't use it for a while, it works again. The other thing is if you take it for prolonged periods of time, everything will turn orange, including like eye discharge. So people can get contacts turn orange, your vaginal discharge. So when everything starts turning orange, probably a good time to stop. And then as far as TENS units, there is some data coming out, not that is published. I've seen abstracts, and I personally do have some patients who use a TENS unit like we do for that percutaneous tibial nerve stimulation. People who travel a lot, who cannot come for treatments. The TENS it's hard because you're a little bit comparing apples and oranges, because with the percutaneous treatment, we're literally putting the needle through the skin right adjacent to the nerve. With a TENS unit, it is those little pads that typically are used for low back pain. So the penetration of the current might be a little harder to get, but you can buy a TENS unit on Amazon. You can place it along that path, your tibial nerve. And I have some patients who, like I said, travel a lot, and in between them coming to the office, they will do a TENS unit. The only thing we can't tell you is what is the exact schedule or regimen. So you kind of have to follow what we do for the percutaneous treatment. You guys have anything to add, Dr. Enger, Dr. Scott?
Yeah, I've seen some studies where they look at putting the pad along the posterior tibial nerve, and then some where they actually put it on the sacrum too. So you could always play around with that.
Thank you. Next question. What are some examples of things that you now recommend based on patient feedback?
Thing that pops in my mind, well, this was years ago. I had a man who had interstitial cystitis, and God love him, he let me try everything on him and just could not really significantly improve him. And I didn't see him for years, and he came back and he was actually doing really well. And he just came back to tell me that the thing that helped him the most was alkaline water, which I would really not have thought that would have worked. I kind of thought it was a little bit hokey, but you know, he was, for all intents and purposes, like a really reasonable guy. I don't think was placebo. So I do think, you know, things like alkaline water, patients have had good luck with aloe juice, aloe capsules, you know, different supplements, which is one of the reasons why we help put Femetry together. So again, back to that multimodal comment that I made earlier, it's not usually one thing, but you know, these are things, again, I didn't even know really what alkaline water was, but I do recommend it quite a bit now.
I would
Thanks.
agree with that. Absolutely. I feel like I've learned so much from my patients, particularly about supplements and more of the things that we don't have in our guidelines. But we always appreciate hearing from patients what has worked for them because they're the ones who are obviously most dedicated to trying things, doing the research on the other options.
Great, thank you. It looks like Kathy's looking for people in New York City. So if you want to direct message her, that would be great. It looks like she's also on Facebook. Next question. What types of food should we stay away from? The web gives some mixed reviews.
Jen, you should take this since you were kind of in charge of publishing the consumables.
Yes, I didn't hear can you repeat the question? I'm looking for it right here.
Sure.
The-
What types of food should we stay away from?
Oh,
The web
perfect.
gives some mixed reviews.
And I honestly refer my patients to the ICA website because that's really really where we get a lot of our information for patients. So it's interesting because studies that it was Rob Moldwin looked at a group of women in New York and largely had what many of you already know: spicy food, red wine, tomatoes, chocolate, right? All the typical foods. What was interesting is we actually did a similar survey for veterans, so about 50% men and women, and they had very similar patterns. So really showing that this is something that is almost, in my mind, I think if someone has food sensitivity, that it almost makes them, it's sort of consistent. It helps me diagnose IC in many ways. And so, but we also don't want to make patients have they don't all need to go on a, very strict diet necessarily. I love the elimination diet is a kind of nice if you're not sure what foods are triggers for you, and then you can add back foods one by one, and then until patients have an understanding of what bothers them. But it does seem, if you look at sort of and again, going back to Lowell Parsons, the idea that acidity, he calls it cations, which are basically potassium molecules that are increased in an acidic environment, that worsens pain. So I do believe in that concept of like what we talked about, and our supplement has that as well, that you can take certain things to reduce acidity in the bladder, and that could be very helpful. But so we know it's a real phenomenon. I think we're still learning which specific foods and for which people how do we make those recommendations? But I think we're getting closer.
Great, thanks. Do ozone treatments work on Hunter's ulcers?
Is that like hyperbaric oxygen? I don't know. I'm not sure.
I think it's ozone. I think it's separate. Yeah.
I mean, there's not really a lot of data for that, even for like hyperbaric oxygen. So, it's one of those things where I doubt it's going to harm you. If the cost is really high, I'm not sure it's worth paying for not knowing what the benefit is. But, again, if you are fortunate enough to be able to afford treatments like that, as long as it doesn't, hurt you, I think it's okay to try. We just don't really have any good data to share with you about that.
Specifically for IC, yeah, hyperbaric oxygen treatment has been studied in like radiation cystitis. So patients who've had cancer and terrible bladder complications, and they do have some benefit. But in those patients, we're typically talking more about significant bleeding, contraction of the bladder.
For Hunter's lesions specifically, the best, at least going by our guidelines, the treatment with a directed treatment with a steroid injected into the ulcer or cautery, I usually do a combination of both, has been shown to have significant impacts on pain. And then for patients who don't respond to that, then that's when, and I think there is a question on the chat about cyclosporin, then you can do a short course of cyclosporin, which is sort of like a systemic anti-inflammatory. Other than that, we don't have great data on like ozone or other treatments for ulcers.
Okay, thank you. Next question. Does natural hormone therapy work? I believe that's what they were typing.
I feel like we
I
need to,
guess
yeah, Dr. Eilber.
yeah, I mean, I guess the question is what, in natural hormones, if there are like Premarin is made from the urine of pregnant mares. So that's a natural hormone. It depends on what you mean. If you mean like compounded hormones, but regardless, for sure, women who are perimenopausal or menopausal, even if you don't have IC, you can start having what we call genitourinary syndrome of menopause. You can start having bladder and vaginal symptoms from that. So yes, I think any hormone therapy can potentially help a woman who is perimenopausal or menopausal. It is not part of necessarily the AUA guidelines, but again, for the interstitial cystitis patient, you have to treat the whole patient with, multimodality therapy.
Okay. Next question is, why is Urabel no longer available? I'm having trouble finding UROMP now.
Good
Any
question.
suggestions?
Good question. I don't know, but it is hard to get. I can tell you that one of the reasons why, even before it was hard to get, it was not covered by insurance any longer because the insurers got really smart. Those are considered compounded medications. And although the individual ingredients in something like Urabel or these combo drugs are FDA approved, as a combination, they are not. And so insurers said, well, we're not going to pay anymore for medications that are FDA approved. You actually look at those medications, they don't have FDA approval, even though the individual ingredients are. So insurers quit paying for those a long time ago. I know it's frustrating. We love Urabel, but it is, my
Right.
patients are saying it's really hard to get. So unfortunately, I don't know why. My guess is it's just not profitable enough.
And Urabel's like it's like the Peridium you could just take indefinitely, which is why we love it. But I must say, I've never actually seen orange tears or saliva. Dr. Eilber, Dr. Scott, have you actually seen that? I feel like Peridium's probably safer than we think.
I've definitely seen orange vaginal discharge.
Interesting. Okay.
Yeah. But that's because most of our patients, we tell them not to take it too long. I mean, but they're the people who didn't know and they just keep taking it.
Right.
Okay, next one. Does bioidentical hormone treatment help with IC?
I think I'm going to give the same answer with a natural hormone. So bioidentical, by definition, is a compound that is identical to our naturally occurring hormone. So bioidenticals, although somehow they have become synonymous with compounded hormones, technically prescription hormones are also bioidentical because our body recognizes them as the same chemical type composition. So there is, again, this misconception that bioidentical hormones are safer, but bioidentical hormones are both available prescription, which are like FDA approved drugs, as well as compounded. And regardless of however you get your bioidentical hormones, yes, they can be helpful for IC, especially in those perimenopausal or menopausal women who are suffering from genitourinary syndrome of menopause.
Great.
I just want to chime in because I see our friend and colleague, Dr. Christine Whitmore, is here joining us. So she's an amazing resource for those in the East Coast. I believe she's in Pennsylvania. I'm not totally sure. And you're welcome to say hi, Dr. Whitmore.
Oh, there she is.
Hi, everybody. I actually practice in Southern New Jersey right now, and I just want to compliment our speakers for a wonderful presentation today and hitting the most important points, and just all of us realizing that interstitial cystitis is not alone. It can be bladder centric, most of the symptoms related to the bladder, but there are other issues going on. In the muscles, in the skin, in the bowels, and other autoimmune disorders. And I think going forward, we need much better research to put it all together. And the MAP study, which is funded by the NIH, the Multidisciplinary Approach to Pelvic Pain, which our ladies here have been involved in, will help us get some of those answers. Thank you.
Thank you.
Thanks for joining.
I'm going to read the next one. I think maybe you answered some of it, but it says, what % of patients with a sacral neuromodulator implant are satisfied? I have heard horror stories about this procedure. What are your thoughts on cyclosporine to prevent reoccurrence of Hunner's lesions?
So yeah, just talking about neuromodulation, we only, and just to like comment on sort of what Dr. Eilber had said is we ideally think about if you're 50% better, then we go on to the second stage. So we don't even put it in unless you're notably better. The rates, and to be totally honest, the rates with interstitial cystitis, the success rates are lower than with overactive bladder, which is gotta go, not making it to the bathroom. But I've had, I would say the majority are at least 50% better. Occasionally now, patients, and we had talked about the central pain phenomenon, patients with IC there is a higher rate of later getting the device removed. And I think that could be because patients who have IC are more sensitive to pain. So they might be more likely to feel annoyed from the device. But again, these can be completely removed. So with overactive bladder, success rates of going on to stage 2, so 50% or better, about 80 to 90%, depending on the implanter. With IC, they're more like somewhere between, I think in my own hands, maybe around 70 to 80%. In the literature, it can be a little bit lower, but I think it's still a very successful treatment and worth a try if you're thinking about it.
Thank
Oh,
you.
this is neat. And then
Okay.
actually, Judy Gibson said that the InterStim was a godsend and relieved 100% of her pain. So that's nice to hear, Judy.
Well, I don't want to argue the part about hearing the horror stories. I think back to, I hear all the time someone had treatment for something or their friend and it was horrible. You also have to pick the right providers. So someone who only does InterStim a few times a year is not going to give you a good office experience. They're not used to doing those procedures. So make sure, again, that you see someone who is experienced for those, because anything can be a horror story if you don't see the right person. And the cyclosporine, I have not used it personally. I know that it is, I believe that there's a paper that showed it was equivalent to Elmeron, which, people will argue if it's that great. It makes sense because cyclosporine is used for to prevent rejection, like in transplant patients. So it suppresses the immune system, similar to why we inject steroid into Hunner's lesions. Again, the only problem is that it's definitely off label, and I would imagine cyclosporin is probably not a cheap drug.
And it is, yeah, in terms of like our guideline is recommended not to be taken chronically as much as for patients who don't respond to an injection of the Hunner's lesion. But so these sorts of things like steroids and cyclosporin, they may make you feel better, but they have more side effects if they're used chronically. So we're just a little more careful with those meds.
Thank you. The next one is, what about natural supplements for pain frequency? Can the doctors recommend?
Funny you should ask. So based on a lot of the things our patients have told us, and I don't want to take up too much time telling the story, but the bottom line is we had one of our trainees was with us and saying, you guys recommend supplements so much, and some of the more, common ones that you do, why not put it all together into a supplement that makes it easier to take, and the ones that are also have some research behind it, which is how we got involved in Femetry, because we saw our patients taking the same ingredients, and we want to make sure that at least, again, science is not hard for a lot of supplements, but at least the ones that we do know, and just from our own clinical experience. So I am a huge proponent for supplements for myself for conditions other than IC. I had some hair loss issues, so I am all about supplements, but also with the warning, be careful, because I also had my physical the other week, and apparently my vitamin D level was almost toxic because I took that to the next level. So just everything in moderation.
Okay, thank you. Next question. Do any of you use or recommend vaginal suppositories made from Valium, baclofen, and lidocaine? Do you recommend use of estrogen as part of a bladder protocol?
Dr. Scott, you want to take that one?
Yeah, I think we all really like to use vaginal suppositories, particularly if we identify concomitant pelvic floor muscle dysfunction. So these are, again, directly delivering these medications to the nerves in the muscle. And so hopefully less systemic side effects, although even with the vaginal Valium, you can still have some, systemic absorption. They're tricky to get, so you typically have to find like a good compounding pharmacy. But these are fantastic treatment modalities. Regarding the estrogen, again, like Dr. Eilber said, hormones are great for perimenopausal, menopausal women, and certainly can help reduce some of the aggravating IC symptoms. The vaginal estrogen is great because if you don't want to take it systemically, then you can use it just for the targeted genitourinary symptoms.
And just to add, for men, we actually recommend them. You can use them intrarectally as well. Not the estrogen, just the Valium.
Thank you. Okay, next up. What is the best way to diagnose IC? I've seen a couple urogynecologists, and one says I have IC, and the others say I don't. And some of my symptoms don't match typical IC symptoms. So how do you know which treatments may help? I've tried many of the non-invasive treatments for bladder pain and frequency with no help.
Dr. Angry, want to take that one?
Sure. So, we used to have, it used to be considered a diagnosis by exclusion. Like if you don't have this and this, then you have IC. And now we really, because people were not getting diagnosed adequately, especially men. And I love that there's men on this webinar as well, because again, it's really underdiagnosed in men. All that you need for diagnosis of IC is bladder-centric pain for 6 weeks in duration that's not associated with a urinary tract infection. So, but sometimes they may have a UTI and then the pain persists, and then it takes a little longer than 6 weeks to identify whether or not it is in fact IC. What we often see is patients who are treated maybe 1, maybe 2, maybe 3, maybe 4 times with antibiotics, only to discover, wait, all my cultures are negative, and that's how we diagnose it. Now, our practice, at least my practice, is once patients have clinical symptoms consistent with IC, I perform a cystoscopy because I like to identify if I have patients with Hunner's lesions, just because we can treat those very differently with a local treatment with the injection. So my practice is to include cystoscopy as part of my workup, but I don't, but really all you need is that a clinical diagnosis basically made by history and physical exam. But I'm interested in what my colleagues' thoughts are on that too.
I would absolutely agree. I was gonna say I absolutely agree with that approach. I think I don't perform the cystoscopy on everyone. I think someone had the comment, I'm in so much pain. I don't want more pain from these procedures. So I think just having the discussion with patients is really important. Some patients, are going to come to you like I've been seeing doctors for 5 years. Okay, that patient, probably more likely going to want to have the cystoscopy compared to the more newly diagnosed patients. So just absolutely having good discussions with patients and coming up again with the best treatment that's going to fit them. I think specifically for this patient or this person who commented, some of my symptoms don't match typical IC symptoms. So there could be other things going on as well. Maybe we have to treat the IC, but we have to add on other treatments for different types of pelvic pain. So making sure that you're considering other specialists. Maybe you have a component of endometriosis, more of a gynecologic oriented pain or gastroenterologic symptoms. So certainly considering maybe you have IC, but other things that need to be treated as well.
Thank you. Next question. I've had IC pain for 40 plus years and had hoped to hear new treatments discussed today. What's on the horizon?
I think that using things like Botox into the bladder, which Dr. Anger mentioned, there is a clinical trial ongoing. There are people who use it now, just like the neuromodulation. It's off-label, but because most people have the diagnosis of frequency and urgency, it's applicable. Other than that, there's not really a lot of new stuff on the horizon. Unfortunately, no one's working on any new drugs as far as I know, but hopefully though, with a community like this, people will encourage investigators and other physicians to look for something new. But the Botox in the bladder being studied specifically for IC is probably the latest thing that's on the horizon.
I think Dr. Eilber's point, we've almost had to take a few steps backwards with IC in terms of developing treatment options. And we're saying, hey, well, let's actually, we don't even really know what's causing it for so many patients. So we're still kind of more in that discovery phase, but still in the laboratory trying to understand the mechanisms. And then hopefully with that, more targeted treatments will come.
Thanks. Next up, what do you think of acupuncture for pain?
Basically, the tibial nerve stimulation is like acupuncture. The advantage is it's covered by insurance, but I have lots of patients who, use acupuncture for pain. Again, you should see an acupuncturist who, is licensed and who is properly trained. I mean, because I don't think acupuncturists have the same probably legal requirements in terms of licensing. So you have to just be careful that someone's just not hanging their sign saying they're acupuncturist. But I mean, acupuncture's been around for centuries. So there's got to be something to that. And I've had people attest, at least for me, if someone says, oh, I've been doing acupuncture for my bladder, I say, where do you put the needles? They're like, oh, they put them in my ankle. But if they said they put them like in their forehead, I kind of wonder like how good their acupuncturist is. But absolutely, acupuncture is great.
Thanks. Next up, does pre-leaf really help?
I think so. I mean, there are people definitely who've been using it for a long time.
Yeah.
Patients yeah. Go ahead, Victoria.
I was gonna say, specifically if you have a known dietary trigger and you love like your pizza and you know that the tomato sauce is really going to trigger you, if you take it before a known trigger, then I've heard a lot of good success from patients as well.
Great. Do you recommend PT, internal, external, for IC?
Absolutely.
Yes, and yes.
Yes.
Great.
All right, I have to give the same plug though. You got to see a pelvic floor PT. I have patients who, they've got their physical therapist for other reasons, so they trust them, which of course you do, but they really should be specialized in pelvic floor PT. You cannot just see a general physical therapist.
Thanks. Next question. Are there any treatments for pain during sex aside from physical therapy?
The vaginal Valium that was mentioned, that is compound, we have some women who will use that before intercourse, especially if the pain is because they get so tight and the anxiety of more pain occurring. Sometimes using the interstim will help with things like that. Yeah, there are definitely other things, although I have to say physical therapy, in my experience, is probably one of the most important modalities to have, but there are definitely other things other than physical therapy.
Right. Okay, I'm going down here. What dosage of vaginal suppository? That was one of our questions.
So it depends on what you have in the suppository. So we often do a combination of lidocaine, gabapentin, or Neurontin, Valium, like, which is actually a muscle relaxer that makes you sleepy. If for patients who, if their insurance doesn't cover like a compounded suppository, I'll prescribe oral Valium and have them put 5 milligrams in the vagina at night. So it's really kind of at the provider discretion. But if you have certain things you want in the suppository that you'd like to request, many compounding pharmacies can definitely make those for you. Oh, and the rectal foam, I know Dr. Soders, who's one of our colleagues, is involved in that, but that is a new study that that's, I think, on the horizon, which is really interesting. But I don't know too much about it. I'm not sure if Dr. Scott, if you've heard of that either.
I've only heard of the study, but not about the outcomes.
But yeah, that's a good one for, I think we should get involved.
It looks like we just have a few more. Kathy writes, before you were born, I took a supplement of combined kapha, and St. John's wort by Twin Labs, and it worked for me really well, but they removed it from the market. Any knowledge about that? I've had IC since 1967, and I'm now 84.
I appreciate that you think we're younger than we are. I mean, St. John's wort is still around. The kapha, I'm surprised if you wouldn't be able to get that individually. It might not be combined, but
Yeah,
I
I
don't
guess.
really, I don't have much experience even with the St. John's wort for IC. That's good to know. I'll have to maybe see if that
Yeah.
that's a good recommendation.
It looks like you would have to take it separately. I'm trying to see online if anything that comes up. But I don't know if kapha is still available. Interesting. There's just coffee, Turkish coffee.
Turkish coffee.
I think we might be out of luck. That's sad.
Hmm. Thank you for that. Next question. How do you feel about daily antibiotics? It says nitrofurantoin as a preventative to prevent an infection which causes flares.
So I will, so many times is I'll have patients who come in that with symptoms that present exactly like a UTI, but they're culture negative. But often they will have had a history of, some of the time they have positive cultures, some of the time it's negative, which means we're suspecting IC. So those patients in that case, when they definitely have a history of positive cultures, as well as flares that are probably not positive, I will put them on low dose macrodantin or any other kind of commonly used preventive antibiotic. It could be Bactrim for those who don't have a sulfa allergy, nitrofurantoin, or even Proliprim, which is Bactrim without the sulfa. I will do a low dose antibiotic daily for about 6 months to get the infection question out of the picture. And then we can actually identify if they are having IC flares. But usually I don't use the antibiotics preventively for patients that don't actually have positive cultures at all. Because then we're sort of treating IC with antibiotics, which, as many of us know, it can really disrupt our natural flora in the vaginal area or urethra.
Okay, thank you. Next question. Are there any scientific theories about why the bladder gag layer becomes damaged?
You can tell from the silence, the answer is no.
Yeah, I mean, there's the cation phenomenon, that acidity in the urine, some people are just more susceptible to having damage from acidic urine. But
Some
I
people
think
think
that,
there's an infectious cause as well, in addition to those other things, but we don't know. Yeah, I agree.
Okay. And I think you addressed the foam questions. And then it looks like the last one is, what do you think of DNA testing for UTI if it does not show up in urine culture?
So DNA is a very hardy structure, if you will. So even if bacteria are dead, you can still have DNA. And DNA tests have definitely not been widely accepted as any type of gold standard yet. I think that if someone persists on having that and they want to treat the antibiotics to see if they get better, I think it's fine. But oftentimes what I'll see is people keep coming back with these positive DNA tests and they get treated and they're no better. So I think we're treating a result as opposed to treating what the person really has. Yeah, so just keep in mind, DNA does not always equate live organism.
mm-hmm. And there are these theories, for example, in England, that a lot of symptoms are from these, what we call biofilms, that there's bacteria hiding in crevices in our bladder. And I'm not saying that those are definitely not there, but when we have those theories do end up causing patients to end up getting over-treated with antibiotics. But we do, I think these are really promising studies, but I do agree with Dr. Eilber that it can end up where you get treated for something that's just there, which may just be living there or not even living, but being dead there. And we end up over treating. So we just have to be careful about those, sort of these new technologies.
Okay, we had two more questions pop in. Would you like to just take those two and then we'll wrap it up? Okay. Next one. My gynecologist recommended a prebiotic probiotic called Happy V after examining my swab. Do you have any thoughts about that?
I think it's important for everyone to know that if you swab anyone's vagina, you will have organism. That is normal. Our vagina is full of lots of different organisms. The best probiotic or prebiotic, however you want to call it, for the vagina, if you are perimenopausal or menopausal, is vaginal estrogen, because it promotes growth of the good bacteria. And also, although there are certain common good bacteria, we don't really know, like everyone has their own individual microbiome. So for me personally, the best probiotics are avoiding antibiotics excessively, which we see a lot of getting treated. And then the reason why vaginal estrogen is so important is the vaginal lining becomes thin with perimenopause and menopause. It is the cells that are shed from the lining of the vagina that provides food for the good bacteria, which is predominantly the lactobacillus or Lactobacillus acidophilus. Those lactobacilli make lactic acid, which helps to keep the vagina normally acidic, and that acidity keeps the other organisms in check. So that's why, it's same with like the preventive antibiotic. Yes, these things are sometimes necessary, but it's better, at least in my opinion, to treat the underlying problem.
Thank you. What do you think of peptide therapy?
I love peptide cream for my face, but I don't know. I do believe in peptides. I just don't know there's anything out there for IC just as of yet.
Okay. One more popped in, and then I promise this will be it, because she sent it right when we were saying that was going to be the last one. Are you aware of viruses that cause Hunner's ulcers?
That's a really great question. And I think there are certain studies being done looking at what we call the microbiome that, do are Hunner's lesions associated maybe with bacteria that we're not capturing or viruses. But I don't think we know that yet.
Yeah.
But we want to know that. We're going to study that.
But they're really hard to grow. But I think that's also, it's very thought provoking. Maybe that's why when we burn the ulcers, people get better, because maybe we're killing a local, collection of some type of organism. But yeah, it's a great question. We just don't know the answer to it.
Okay. Wow. Well, thank you so much for being here with us today, Doctors Anger, Eilber, and Scott. Today's session was so informative, and you went above and beyond by answering all the questions, and we are so grateful. We hope that all of you enjoyed this webinar and learned something new. If you found this event to be of value, please consider joining us for future webinars and share these opportunities with your community. We'd also like you to mark your calendar for June 26th for our next webinar, titled Your Journey in Clinical Trials, Expectations and Impact. Our speaker will be Dr. Robert Moldwin, ICA Medical Advisory Council member, and the link will be in the chat. We just wanted to let you know also that we are marking our 40th anniversary this year. And this is significant because the ICA has been the sole nonprofit organization dedicated to ICBPS for 4 decades. So please be sure to keep an eye on your inbox for ICA emails, follow us on social media, and participate in our 40th anniversary activities. So thanks again for joining us today, and we look forward to seeing you on future webinars. Thanks, everyone.
Thank you, everyone.
Thank
Thank
you.
you.